Hi guys, it's Professor Costa, and we're going to be talking about care of patients with altered oxygenation, and this is just part one. I know these videos are kind of hard to watch all in one chunk, and so I broke it up, hopefully a little bit better for you. Okay. So gas exchange, this comes right out of your Giddens book. So this, when we went over gas exchange in semester one, this should be a similar slide to what you've learned off before. Some things that I know you know how people breathe. You've taken anatomy and physiology, but some nice things to pull off of this slide that I'd like you to remember is that at sea level, where like we live in Rhode Island, atmospheric oxygen concentration is about 21%. I don't know if you knew that or not, but room air is 21% FiO2. So that's the fraction of inspired O2. And this changes depending on elevation. So if you live in like the mile-high city of Denver, Colorado, you're actually breathing a little bit less oxygen. So it takes a toll on people. Let's say you have COPD here and maybe you're doing okay, but then you go to see your grandchildren in Denver. Just realize that those people may actually have difficulty. And the further up you go, the less oxygen there is. So that's why people who climb, Mount Everest, not that I'll ever do that, but if you decide you're going to be that adventurous and climb Mount Everest, the higher up you go, the less oxygen there actually is in the air. And that's why those people end up using O2 tanks to reach the summit of Mount Everest. So remember too that our brain has a breathing center, and that's where our body actually decides to take a breath, right? So, and it's done, we'll go over this in another slide, but it's actually controlled by levels of CO2 in a healthy adult, okay? So a lot of things have to happen. You have to have oxygen available. You have to have an intact breathing drive. You have to have a highway system. You also have to have muscles that work, right? The diaphragm, the thorax, the pocket that contains our lungs, our chest has to not have holes poked in it. The diaphragm has to contract, it's a muscle. And then we have to have the highway system intact. Nose, trachea, bronchi, alveoli, all those little sections where air travels into our lungs have to be open and available, open to traffic, all right? And then we have to have an intact circulatory system. So we have to have good perfusion to the lungs. So where we have gas exchange, right? So we either, trouble with oxygenation is either air can't get in or it can't get out, or we have a problem with perfusion in some patients with like a PE where there's nothing wrong with the ability for oxygen to come in, it's just there's no gas exchange, so there's no perfusion occurring, okay? All right, so a VQ mismatch. I don't know why perfusion is called Q. Probably because some doctor somewhere thought it sounded good or it's a mathematical thing. I don't know. V is ventilation, so that makes sense to me. So a VQ mismatch is the most common cause of impaired gas exchange. So normal ventilation is about 4 liters per minute. You're able to breathe in about 4 liters of air every minute, and we're able to perfuse about 5 liters a minute. So we have a little bit better ability to perfuse than we do to bring the air in. So the normal VQ ratio is about 0.8 or 4/5, okay? So a mismatch occurs if either the ventilation is decreased, i.e. you're not taking breaths, maybe, you went to Kennedy Plaza and scored some Vikes or something, or Q is decreased, so the perfusion is decreased, either from a direct blockage of perfusion, such as from a blood clot or, a PE, or something more sinister like CHF. So there's not enough pumping activities, there's not enough blood circulating, and therefore you don't have good perfusion. You can have great ventilation and still be oxygen deprived because of the perfusion issue. So I named 2 of the things right there. So we can either have a direct block, or we could have impaired ventilation with things like secretions or pneumonia. So it's either a ventilation issue or it's a perfusion issue, or sometimes a combination of both. when this summer, I know I may take this PowerPoint, use it again in the future, but this summer we're dealing with something very insidious, COVID-19. And unfortunately, when it first appeared, we thought it was just a true ventilation issue, that like a pneumonia. But now it's becoming more and more evident that it's a combination. Not only does it cause a pneumonia, but it also causes blood clots to form. So then you can have a combined VQ issue with these patients, which is just awful. All right, so ventilation, perfusion, VQ, gas exchange. All right. So in the middle, we have our nice, happy, normal alveoli in the middle over here, right? Sorry, trying to let you see here. I'm not very good at this online stuff. So here's our normal one, right? You can see that the air can come in and go out, and we have blood flow coming in and blood flow coming out, right? So the CO2 laden blood comes here, there's gas exchange, oxygen's coming in, and now oxygen's getting delivered, right? So venous blood has more CO2 in it, and arterial blood has more oxygen in it. If we come over here, we see that there's something blocking the ventilation. So maybe a pneumonia, or maybe you swallowed a hot dog and are choking on it, and we've blocked the airway. But there's nothing wrong with the perfusion. So what happens is something called a shunt, meaning blood circulates through here like it's supposed to, but it doesn't, no gas exchange occurs, and that's called a shunt, okay? Then over here, what we can have is we can have nothing wrong with the airway system. Air can go in, it can go out, but there is no circulation over here. So ventilation without perfusion. This is where our PE comes into play. And unfortunately, what that causes is dead space, meaning the air's going in and going out, but there's no gas exchange, and that's not good either. All right, so acute respiratory failure equals impaired gas exchange. And there's two big kinds, all right? There's hypoxemic, which is a decreased oxygen saturation, or PaO2. So this is something the students get confused about. So we have PaO2 and SaO2 and pulse ox. So when we're directly measuring the amount of oxygen in your blood, not indirect measurement like pulse ox, but we're directly measuring it. We drew arterial blood gas, and we're measuring how many millimeters of mercury of oxygen is in the blood sample. That's the partial pressure of O2, that PaO2, okay? A pulse ox and SpO2 is an indirect measurement. It looks inside one little, cell. It looks at the hemoglobin and it says, oh, that hemoglobin molecule has 96% of the oxygen it's capable of carrying, right? So I think of hemoglobin like little oxygen buckets swimming around. And when you look at a pulse ox or SpO2, you're looking inside one bucket, right? Oh, that bucket's pretty full. Yay, us. And it assumes that we have enough buckets, okay? That's not a direct measure. Direct measurement is in arterial blood gas. So SpO2 can be fooled by some things, like notoriously, if our patient is severely anemic, yeah, you may have half as many buckets. Your hemoglobin may be 6. So it's not really that hard to fill those up with enough oxygen. So you can have a patient who's satting at 99%, their SpO2 is 99%, but is overall oxygen deprived because they don't have enough hemoglobin in the first place. All right, so don't always trust an SpO2. We want to look at our patient. If our patient looks blue or is gasping or says, I can't breathe, then they're hypoxic no matter what the pulse ox says, okay? The other kind of respiratory failure is hypercapnic, and that's an increased CO2 level, carbon dioxide level, all right? So inadequate CO2 removal, and it's measured from a ABG, it's a CO2 level of greater than 45 millimeters of mercury. So these are pressures, which is what the P stands for, right? Partial pressure. Okay. When we breathe normally, and again, this gets students a little bit confused. If you haven't been smoking, Lucky Strikes or Pall Malls for the last 50 years, you breathe using a hypercapnic drive, meaning when your CO2 level gets too high, your brain signals you to take a breath, right? So that's how we normally breathe. It works pretty efficiently and pretty quickly. So I don't smoke, I've never smoked, I don't have COPD, my body's running on hypercapnic, okay? Unfortunately, we have a lot of people that damage that through years of smoking or other recreational things that damage their lungs, or even occupational. But for whatever reason, that CO2 detector that normally keeps us breathing has been damaged. And what happens with our COPD patients who are chronic CO2 retainers, because they just can't get the air back out. They've lost that elasticity that those the balloons need to squeeze back the air out. They run on a hypoxic drive, meaning they don't take a breath until their O2 sats drop, which is kind of scary. It's a backup mechanism that, for every primary system our body has, it always has a backup. And so we've broken the CO2 detector, so now we're going with the low oxygen. So that's why we say with patients who have COPD that we want to carefully titrate their oxygen, because if you give them too much oxygen all at once, then it may limit their brain's ability to signal that they have to take a breath. So sometimes they will hypoventilate, meaning they don't take enough breaths because we've given them too much oxygen all at once. That being said, that doesn't mean you don't give oxygen to a patient who has COPD, who is symptomatic and definitely in respiratory distress. All I'm saying is that we would titrate it carefully. Start with 1 liter, then 2 liters, and 3, all right? So if you have someone who's blue and says, I can't breathe, then we're not going to dilly-dally around, all right? I consider this like a forest fire, and I'm not going to put, little dropperfuls of water on that forest fire. If someone says, I can't breathe, and they're turning blue, you're going to pull out a larger oxygen delivery device. You're not going to go with a nasal cannula. You're going to go with a mask, okay? So don't get caught up. Students always yell like, oh, I was always taught that if they have COPD that you are really careful with the oxygen, you don't give them much. No, what we're saying is that if you need to give them oxygen, you have to be very careful and titrate it, all right? Unless you have something, acute respiratory failure, that we're all stops. We're going to put on as much oxygen as we need to bring them up in a hurry, okay? But for routine maintenance of our COPD patients, yes, we will be very careful with titrating that because we can slow their breathing down to where they don't breathe anymore. Okay, so acute respiratory failure causes. We have extrapulmonary causes, meaning outside of the lungs, right? So what could cause a problem with us breathing or exchanging air? Neuromuscular disorders like myasthenia gravis or polio or Guillain-Barré, where the muscles that we need to help move that diaphragm aren't working very well, the intercostals, whatever. Usually it's a diaphragmatic issue, right? The muscles that help control breathing aren't working. Or chemical depression, right? So meds are really usually the culprit here, like our trip to Kennedy Plaza and an opiate, really common culprit. All right, massive obesity. So remember, there are muscles at work here, and if you have someone that's carrying 500 pounds in their stomach, then the muscle has a lot to work against, and you may have acute respiratory failure. Central nervous system dysfunction, so they could have had a stroke or meningitis. Spinal cord injuries, all are extrapulmonary causes of acute respiratory failure. Intrapulmonary causes within the lung, a VQ mismatch, PE, ARDS, a pneumothorax, pulmonary edema, or pneumonia. All right. Sometimes these problems are combined, like our case of severe CHF, which can cause both low perfusion and pulmonary edema, right? So sometimes there's a mix. Okay, so risk factors for this: fluid overload, right? Not all things are benign. Remember that too much fluid is a bad thing, even in a young, healthy adult. Chronic pulmonary diseases, COPD and emphysema, right? Smoking is the number one risk factor for developing this. We know that. And nowadays, it isn't just smoking, it's vaping. Vaping is horrible. And we also have those environmental issues of people that worked on with boats and asbestos. And I'm sure you've seen those mesothelioma commercials if you stay up late at night. Chest trauma. So if you've been in a motor vehicle accident, it requires an intact torso. So if you have a puncture or severe contusions, then that can develop into acute respiratory failure. Thromboembolic disease, so blood clots, DVT, PE, and obesity. All right. I don't know if you can tell in person, my slide, you can tell that this person is very hypoxic. Their fingertips are blue. But clinical manifestations of hypoxic acute respiratory failure is the problem. Remember, this is hypoxic. It's not enough O2 coming in, or O2 cannot be exchanged and perfused. Dyspnea. So the person's going to feel short of breath. They're going to complain of difficulty breathing. Or you may notice that they have accessory muscle use, meaning you can see them trying to breathe. When people are eupnic, and eupnic is just a term meaning normal breathing, you don't notice them breathing, right? So if you come into a room, you're in your living room watching TV, and you go and you see your kid just looks normal and they look like they're just watching TV. You shouldn't notice breathing. If you notice breathing in a patient, that's usually like if you pick up, something's going on with their breathing, that's usually a sign of dyspnea, okay? Orthopnea is that people who have acute respiratory failure definitely will do better with their head of the bed up. There's also something called orthopnea, where people have difficulty breathing laying flat. Sometimes we assess this in patients by asking the pillow rule. I don't know if you have ever heard this on an assessment, but you ask them, how many pillows do you need to sleep at night? So there are people that, oh no, I only need one pillow. And then there are people who have chronic respiratory disease and they'll say, oh no, I have to sit up in my recliner to sleep, or I have 4 pillows. If I lay flat, I can't breathe. Orthopnea is really common too in patients who suffer from obesity. Okay. Low SpO2, so you put the probe on and it's reading low, less than 92%. Abnormal ABG. So if we have a PaO2, remember we're talking pressure of oxygen and we're talking hypoxia, okay? If it's less than 60, you are for sure hypoxic. A normal PaO2, a ballpark, is at least 80. So around 80 is a normal PaO2. That's why I don't want you to confuse it with SpO2. SpO2 is pulse ox, that indirect measurement. We want an A in pulse ox. PaO2 around an 80 is okay, and up to we can hit 100 too, but at least an 80 is normal. Okay? If you're less than a 60, then you're really fighting. You're really hypoxic. Okay. So depending on the cause, there may be adventitious lung sounds or absent lung sounds or even normal lung sounds. Remember, if our oxygen issue is a VQ mismatch where the issue is perfusion, that means that the airways are open. So you may hear air going in and out. There's just no perfusion occurring. So that's why an issue like PE, you may hear normal lung sounds, okay? So signs of poor oxygenation include air hunger, restlessness, peripheral or central cyanosis. Central cyanosis is cyanosis that, like circumoral, their lips are turning blue or their tongue is turning blue. That's scary. Peripheral cyanosis is those fingertips or toes. Headache, confusion, tachycardia. When we go over perfusion in another lecture or two, the heart always feeds itself first. It has to take care of itself in order to keep the rest of us alive. So if it senses a drop in its own oxygen availability, it will increase production, meaning it will increase its heart rate in order to improve oxygenation, and then we have a vicious cycle, right? So tachycardia. So we can have something called a demand MI, meaning if the heart does not have enough oxygen to do its normal functions, it will increase its rate to try and improve things. But now we have a heart that's working harder with still poor oxygenation, and we can end up having troponin, an increase in troponin levels, meaning that heart muscle is dying because of this. And because of that, the patient may experience some chest pain. Also, too, if you have a PE, it hurts. If you have pneumonia and coughing, you can have chest pain. So chest pain isn't always cardiac. It could be lung related, but I want you to assume that maybe if we have a hypoxic patient who's now complaining of chest pain, that we have some demand going on in the heart. How do we fix it? Well, I always remind my students, if the patient is in distress, don't assess. Okay, what do I mean by that? Do I want you to assess patients? Of course. But if I walk in the room and the patient is gasping for air and turning blue, do I want to take another 10 minutes to do a lung sound assessment and have them roll on their side and let me listen to the bass and can you give me a little cough? No. So if they're truly in distress, we want to fix it first. And how do you fix acute respiratory failure? You give them oxygen. And if they're in true distress, I don't want to wimp around with 1 or 2 little liters of nasal cannula. I'm going for the big guns. I'm going for a mask, all right? And if you're using a mask, any mask, the minimum number of liters per minute, and I mean minimum, is 6. So at least 6 liters by mask, all right? Again, if this is the worst thing that could happen to my patient. I have an A or B problem, airway or breathing problem. Those are my 2 top priorities. I'm going to fix this problem immediately. Then I'll try and figure out why it happened. So if you have a patient that appears to be in acute respiratory failure, they're turning blue, they feel like they can't breathe, you are going to give them oxygen. You are going to sit the head of bed above 45 degrees. So you're going to sit them up if you can. Okay, so that means if they're not in, skeletal traction or just had a spinal cord injury, if it's not going to kill them to sit them up, you're going to sit them up. All right, so we're going to sit the head of the bed up. We're going to give them oxygen. We're going to assist with respirations if we need to, right? So mechanical ventilation if it's severe, or we're going to bag using a bag valve mask, aka ambu bag, right? We may have to assist with respirations. An MDI, which is a metered dose inhaler. So if we think it's because of asthma or COPD, or there's an inflammatory process going on, then we're going to give them an inhaler or a nebulizer treatment. Or if we think it's that they're all junky or chunky or they've got, secretions, then we may suction them, right? But we want to put the head of bed up and we want to give them oxygen, right? And am I going to leave the patient by themselves? No. If you have someone in acute respiratory failure, you are staying in the room. You are calling for help. Rapid response, or depending on where you are, if you work in a long-term care facility, that may just be a 911 phone call. Okay, but you cannot do this by yourself. If this patient needs an advanced airway, you are an RN. You do not put in advanced airways. All right, you need help. But we're going to stay with the patient. We're going to put their head up and we're going to give them some oxygen right away. And then we'll see what else we can do. I can't breathe. All right, so looking at our normal pH, remember our body, our homeostasis, happy pH is a pretty narrow margin, right? Our body does not tolerate pHs outside of the norm. So normal is between 7.35 and 7.45. So if we go above 7.45, we're in an alkalosis, right? And if we're below 7.35, we're in an acidosis. Now, see, it doesn't go to, if we're trending down towards a 7, we're going to die. If we're trending up towards an 8, oh, we're going to die. So it's a very narrow margin, and our body has some compensatory mechanisms to help with that. This is not new content. ABGs are not new, but we're going to be looking more at how our body compensates for these things. So, laboratory test, an arterial blood gas. Remember, a pulse ox is great, and SpO2 is a great thing. We do it all the time. It is screening, but we do not measure actual amounts of oxygen in the blood using an SpO2. We do that by drawing an arterial blood gas, all right? And it is the most useful test for acid-base assessment, all right? So, again, this isn't new. You should have memorized this already, right? So a normal pH is between 7.35 and 7.45. A normal CO2, remember partial pressure, that's what the P is for, normal is 35 to 45 millimeters of mercury. A normal PO2 or PaO2, partial pressure of oxygen, is around 80 to 100, okay? 60 to 70 in little babies, and they're not, great at breathing yet. And a bicarb, an HCO3, bicarb, the normal, okay, this is the only number that changes a little bit depending on the textbook you look at, okay? So I want you to think mid-20s, right? So 22 to 26 in this textbook. I've seen 21 to 30, mid-20s. Ballpark it in the middle. Go, a bicarb around 25 is decent, right? And then a total CO2, right, measures all forms of CO2 in the blood. All right, so what kind of conditions and what does that mean? So if we're in a respiratory acidosis, that means that we're retaining CO2, so the CO2 level is going to be above normal, right? And our bicarb, so the CO2 is managed by the lungs, and the bicarb is managed by your kidneys, right? Your lungs can react way quicker than your kidneys. All right. So in a respiratory acidosis, you're going to see a CO2 level that's high, and you're hopefully going to see a bicarb level that's high because of renal compensation, right? So if I have an ABG where I have a normal pH, but my other levels are high, that means my patient is in something called a compensated respiratory acidosis, right? That, yeah, I'm retaining CO2, but my kidneys had time to work around and normalize my pH, all right? A respiratory alkalosis would mean a PCO2 below normal, and I'd have a below normal bicarb, renal compensation, right? A metabolic acidosis, I would have a below normal CO2 level and a below normal bicarb. All right, so a respiratory alkalosis and a metabolic acidosis, you're like, whoa, how am I supposed to figure that out? Well, we'll look at the numbers too, okay? A metabolic alkalosis is an above normal PCO2 and an above normal bicarb. All right, so let's play ABG tic-tac-toe. And I do have a YouTube video about that goes into this a little bit more that I will be posting so you can watch the whole video. All right, so let's look. Our pH is 7.29, and we have to remember our norms, which are down here underneath, right? So our over here, our pH is normal is 7.35 to 7.45. So pH is 7.29 is an acidic pH, okay? PaCO2, remember partial pressure of CO2 is 50. And if our normal is 35 to 45 and greater than 45 means acid, then that means I have an acid. And my bicarb is 25. Well, that's actually a normal bicarb level, so that's normal. So who's in the column with me? Tic-tac-toe. Well, if my pH is in the same column as my CO2, then that means I have a respiratory acidosis. Whose fault is it? Remember, the lungs controlled CO2 and the kidneys control bicarb. And the kidneys are part of metabolism. All right, so here's another one. So we have a pH of 7.38. And if we look at our, that's normal, right? So if you have a normal pH, but then you look at your other numbers and they're both off or one is off, then you have some kind of compensation going on. So we'll have to do some more figuring on this. So my PaCO2, my CO2 level is in the acid, it's way too high, and my bicarb is 30. So that's in the base. So now you're like, oh, great, thanks a lot, Professor Koss. Now how am I supposed to figure this out? Well, now we're going to split hairs. If we have a normal pH, an abnormal CO2 and bicarbs, then we have to figure out whose fault it is. So we're going to split the difference, right? So we're going to put 7.40 smack dab in the middle. And now we're going to reassign the pH, right? So we're going to take it out of the normal column and we're going to stick it over in the acid column because we're going to use 7.4 as our new normal. And when we do that, tic-tac-toe, we'll see that the culprit is most likely respiratory in cause, and we have a compensated respiratory acidosis. Some other clues that will be in this ABG problem will be things like it'll be kind of easy to tell that it's respiratory in cause because we'll give you something else about the patient, like a PaO2 level. So if I said in this patient that they have a normal pH, but their PaO2 was 70, then that would be a clue because that's below 80 that this probably has a respiratory cause. Again, I left my video about ABGs, the ABG tic-tac-toe up, so feel free to watch that again, okay?